at POLITICO, we convened a working group on opioids. And it was actually an incredibly sort of high-powered group of people. We had the Surgeon General, we had people from the FDA, the CDC, NIH, some other government agency I can't remember right now, a number of physicians, people who work with addiction medicine, pain specialists. It was a really provocative conversation. And in the 8 or 9 months since then, the more I think about this problem and the more I learn about this problem, the more complicated I think it is. Your experience is really different than the kid with the broken ankle or maybe the sprain. And I've met patients here today who've told me they can't live without responsible, proper use of opioids by a doctor watching them. And I've met patients who said, I don't need them anymore. Okay? I think the problem isn't so much, I think, and the conversation, the national conversation has also really been about chronic pain, but I think Jean Marie pointed out that before you have chronic pain, for many patients, I mean, we're obviously generalizing, there are different conditions. Before you have the chronic pain, you have that first acute episode. And that is sort of this magic moment when it can go really wrong. This is also an audience here where we talk a lot about tech. Many of you are and we are in Silicon Valley. And I'd like to explore a little bit more about some of the things Cindy talked to about and how the physicians are using these databases and the tools and how to make it easier for them to do what is good for patients. And then I really think it's also a matter of culture, and that was the title of our working group, actually. It was the culture of prescribing, how to make doctors think differently. But I think it's also patience, because we are a very quick fix society. As you pointed out, we have a payment system that promotes quick fix. As you pointed out, Frank, you have an insurance system that makes you do things quickly. So I'd like to talk, I actually sort of want to start talking with some of the things Cindy talked about, let's start with some of the tool and how it's evolving. I mean, and then I want to sort of talk about how do we bring about change, and I want you to talk about summer camp. But let's talk about the PDMP, which I always forget exactly what it stands for: Prescription Data Bank.
Prescription Drug Monitoring Program.
It's the data bank with all the drugs in it. And for most doctors, it's separate from their EHR, right? Their electronic medical record. So you've got one electronic thing that every doctor hates, and you've got another thing they have to then click out of and then click into and then click out of again. Is that sort of how it mostly works?
That is correct, unfortunately, at this moment. In a lot of systems, there are efforts underway to better integrate them, but we're not there yet. And unfortunately, that serves as a major barrier in terms of the use of this information.
And you outlined sort of some new tools that physicians can use, that you can set these instant alerts so the information comes to you instead of you going to the information. Because I think the word everybody uses is clunky about anything that doctors have to use electronically. And how common is that? Is that easy to do? Is there something, this is still a think tank thing that is not in the real world yet?
So with unsolicited reports, which was the first practice I talked about, a majority of states are already doing those and have been for a number of years. Some of the other things, the prescriber set thresholds, which I think are a wonderful tool in terms of being able to engage with your patient, in terms of facilitating that dialogue about how their pain is being managed. That's more rare. We're not seeing as much of that yet, but as I mentioned, we're at a stage where the states are actively engaged in trying to improve those systems. And I mentioned that prescribers should provide feedback. And if you look at the literature in this area, there are always surveys of prescribers in terms of what do you think of these databases. And a lot of times the response rate is 10%. So if you have an opportunity to provide your input, the states are listening and they want your input. And really only through that can these systems be improved so you can provide better patient care, which is really the key. It's information to help guide your clinical decision making and your encounter with your patients.
Britt, you wanted to say something?
Yeah, but the problem with some of those drug reporting systems like Cures here in California is that it is purely data driven and there's no narrative attached to any of those numbers there. Because I'm an e-patient. I was willing to get access, or was able to get access to mine this last year, and found that there was a clerical error on mine because of a resident in my hospital had entered something wrong on there, and it essentially made me look suspicious when I hadn't changed my behavior in 18 months. And so I'm not able to change that. My doctor's not able to change that at this point, and now there's no narrative attached to that.
So how can she change that?
So in a number of states, and first off, if you're a prescriber, I would encourage you, most states will allow you to look at this information. Increasingly, they're allowing patients to look at this information, and they should, because like all data systems, they're not perfect, they're largely accurate, but there can be information on a prescription that's not legible, or in a multiple practice setting, which prescriber really prescribed it. Was it you or was it your colleague? So everyone should have an opportunity to provide a review of this data. And I agree that it's just a data point, but it's an important data point, and it's, I can't emphasize enough that it's information to start a dialogue. I mean, you do hear that prescribers will on occasion use this information to dismiss patients from their practice. That is so rare, fortunately, but it should never happen. The information should be used to have a conversation with the patient and to improve patient care.
Frank, you practice in both Maryland and DC, if I'm remembering. And we were talking about how, and DC is an example of a place that fixed this, but until recently, or fairly recently, I mean, all of you probably, I mean, in DC, Maryland, DC, and Virginia are like, you can be in all three places within 15 minutes. You could go to 3 different drugstores in the 3 different jurisdictions with 3 different prescriptions from 3 different doctors, and it wouldn't have shown up. So you would have only seen DC, only, you can walk to Maryland from,
Right.
I know where your office is, it's our pediatrician. You can't quite walk to Maryland, but you can bike ride. So DC has now integrated. Has Maryland integrated? You can see all
Maryland,
the...
DC, and Virginia have just started to integrate.
How much of a barrier is that? I mean, if you're in Illinois and you're 15 minutes away from Indiana, does it show up? I mean, how useful are these in actually giving? I mean, patients that do have a problem are pretty smart about figuring out how to work the system. So does the system let them work it?
So particularly in the last couple of years, we've seen a lot of progress in terms of states being able to share data. And we're not quite there yet, but most states do. I know I live in the DC, Maryland area now, and I'm from Philadelphia and lived in New Jersey. So I am well aware of this concept of living in a geographic region where right across the corner you're in a different state. So we've made progress. There's a little bit more to be done in that space.
What do you, I mean, Sean, you're in an academic medical center, you're engaged in research, which I think everybody knows that we need something else and haven't figured out what the something else is. But you're dealing, by definition, you're dealing with complicated patients. Someone doesn't come to a pain specialist typically because they have, a sprained ankle. You're talking, I guess you get some, but with really good insurance. But generally you're dealing with a more complicated and a history and a referral because there's been something that the primary care setting can't take care of, or a coordinated approach or team approach that the various specialists can't take of. What are your tools? Because some people are going to be people who you're saying, all right, like you talked about inheriting Mary, you've got some people who are coming in already with a high dose, and you're saying, I wish they'd never gotten that first prescription. I wouldn't have gone down this path. Is that a rare thing for you, or is that a common thing?
I think it's a common thing. It's actually a little bit less common than what I was seeing probably 5 to 7 years ago. I've been seeing a drop-off in what I refer to as people coming in on orbital doses of opioids. So I think that the media, the rhetoric has really engendered a lot of fear in prescribers, and we're starting to see, I think, some degree of this self-correction on these really high doses. But if I understand your question correctly, it's, what do we do with these patients in that type of an environment? And, I'm blessed to have an environment in which we have all sorts of resources, and we think about the management of any patient across 6 major categories, and those categories are, yes, medication management. Well, I think sometimes what gets lost is that we have about 200 medications that we can use for the treatment of pain, 200, and only a small percentage of those are opioids. So large numbers of meds used for pain. That's one. Two, we have pain psychology. I think it was mentioning before, you have to pay for this. Highly underutilized, highly effective. I lose all sorts of money on pain psychology in our center. We have 6 pain psychologists, but we believe in it and we integrate it. 3, physical and occupational therapy. 4, nerve blocks, procedures. 5, complementary alternative medicine approaches. These are acupuncture, over-the-counter nutraceuticals. And then 6, something that is often not well appreciated, and that is self-management or self-care approaches for pain. And the data has shown very clearly that putting this all together in a team-based environment in one location is where you're going to get the best results.
In the emergency department at Penn, you personally have a very high sensitivity to this issue. You're busy. You're dealing with, I think probably everybody here has been in an ED. They're busy places. They're hectic. You have to make decisions fast. You're juggling multiple patients. How many of your colleagues check the PDMP?
So it's interesting. Pennsylvania was the last state, or maybe Missouri is the final last state.
But Missouri's still hanging out there, right?
We just started our PDMP in the last week of August, so we're about 2 weeks into it. Literally, we had no access to it before that. And it's actually surprising. They came out with a mandate that you have to check it before you prescribe. And I was a little against the concept of a mandated checking because most states don't have mandated checking, especially in a state like ours that waited so long to get it. But I actually like it because I would have checked it more than most people, but now I know that everybody can be held accountable in the same way. And I think they actually are checking it.
And did they figure out a way to make it easy for you?
It's pretty good. It's much better than my skepticism, before it came out. It's a couple clicks. We have to go out and in, but the login's easy, and finding and interpreting the data and finding the patients is pretty quick. And I'm finding it a useful tool, and actually a tool to make me feel better about prescribing much more often than not prescribing. So in other words, I'm not sure about this story, or this patient's new to my health system. Let me just check. And 9 times out of 10, that more often reveals no prescriptions, but I find the patient. So I'm confident that I'm on the right person. They had 1 prescription 6 months ago or something. And then I feel like it's a safe place to go for prescribing. So it's more helpful in the opposite direction of what you might have thought.
Most of what the states are doing, and the guidelines you referred to are guidelines. They're not mandates in terms of, they're not saying you cannot prescribe. They're saying this is the typical situation where these are your parameters. Are more states contemplating making the PDMP check a mandatory check because doctors aren't doing it voluntarily?
Me?
Yeah.
So currently there are, I believe, 32 states that have some type of mandate in place. But there's a lot of variability. So in some states, it may just be the PDMP needs to be checked before you write a prescription for methadone for pain. In other states, it's related to workers' comp prescriptions. There are a number of states that have mandates for every prescription, but not all of them. We are seeing a general move in that direction. And while you would have initially thought there would be some pushback from that on providers, I think they are seeing that it is a tool that helps them provide better care for those patients. And then we also see it adopted with things like delegation, so allowing other members of the staff to access the data to address the workflow and time barriers.
What are some of the obstacles, Frank? You talk about patients coming in, and they want all the obstacles that Rick mentioned that you. What's the easiest thing for a patient? Forget what the easiest thing for you might be to write a prescription, but the easiest thing for a patient is to go to the drugstore and get a prescription, right? You go once every 30 days for a painkiller. You have 1 copay. You don't have to miss work to go to physical therapy. Your insurance covers it, which it doesn't usually. I mean, there's more coverage of acupuncture, but there's still not a lot. Physical therapy has copays. And if you're if you're an hourly worker, if you're a cashier and you're barely making it as it is, and then you have to miss a couple of hours of work to take a bus across town to the PT, pay that copay and deductible, take the bus back to work, you're paying a copay, you're paying your deductible, you're a minimum wage worker, and then you're missing 2 hours of pay 2 or 3 times a week for 3 months. it is logistical, it is financial, it becomes, for me going to PT before work, it's a minor inconvenience. For someone, it becomes burdensome in multiple ways. Yeah. Acupuncture is not usually covered, massage is not usually covered, heat packs are not usually covered, ice is pretty free. But all these other things, are you seeing more payers? For a question for both of you, are you seeing the insurance world beginning to wake up and say, if we want physicians to prescribe fewer opioids because it's actually costing us a lot down the road, are they waking up and saying we need to think about these other things? Or it's still rare? Massachusetts is, Care First is where we live.
I really haven't seen much difference. I mean, like Britt was mentioning, you really have to provide different avenues for patients to be able to seek alternative therapies. And, just for the medications that we are trying to prescribe, for example, non-opioid medications, there's a number of hoops that we have to jump through in order to get them filled by the patient. And so there's, I think pharmaceutical companies are very smart about how they market certain medications, how they ensure that their medications get paid for by...
get on the formulary.
Right, by the formulary. But you have a whole marketing team from a major company that's working on that matter so that it's easier for pain physicians or primary care doctors to just prescribe that. You really don't have that when it comes to things like acupuncture or mind-body therapies, because there isn't an association of marketers or organizations that's actively fighting with insurance.
We don't have an acupuncturist lobby.
Right.
They would have found me if we had one, right?
Yeah.
And what about in California? Are payers beginning to change how they approach, or once they're in your clinic, it's sort of a fee for pain management, and you can?
Yeah, I think they're changing, but it's not for the better. I think what people are using are the guidelines and picking and choosing information from the guidelines to deny care, and I think it's making it more challenging. I've seen in our center more and more administrative burden to get authorization for treatments and services, and so we have our nurses who, some have left because they feel they're glorified secretaries, if you will. They're just filling out paperwork, trying to get authorization. And so it's less and less contact time with patients and more about filling out the paperwork to get the treatments. Mm-hmm. Frank, are you seeing the same thing?
Yeah.
Yeah.
But including for alternative, is it for physical therapy you're having problems, or just the
I
prescriptions?
I think it's across the board. It's from the medications and the formularies that become more and more restrictive. It's the pain psychology, which is highly restrictive. And it is the complementary alternative medicine approaches. I'm not aware of any of the insurances around here that cover, for instance, mindfulness-based stress reduction, which the data is great on. The only saving grace is it's about $300 for 10 sessions. And so usually what we were doing is giving it away just to get people in.
And has that been, can you say, okay, it's $300. Is there any incentive for people to research that, to come up with the evidence body to say, hey, this works better than these fancy drugs, start paying for it? Where are we in looking at those kind of things?
We're actively doing it. So, despite being a doctoral level engineer and a very mechanistic guy, I'm told I talk more like a psychologist these days. And so we have a big NIH center grant that's actually investigating the mechanisms of mindfulness-based stress reduction, cognitive behavioral therapy, acupuncture, to try to understand not necessarily what works better than the other, but why do these work? For whom do they work? Because we have to get away from the cookie cutter approach of just assuming that, just because something reaches threshold in a randomized controlled trial, that it's going to work for everyone.
And Jimmy, you when I met you last year, you told a story about coming out of your day-to-day work where you deal with young people dying of overdoses and having to go to tell the story. The person you told about, Joey, I think his name was, that's your life, day after day. And then you said you went to work at your teenage daughter's summer camp. And I remember this very well. And there were 13-year-old and 14-year-old girls coming into the infirmary with cramps, and they were getting opioids. Did you go back this summer and had it changed, or did you like not be able to deal with it and didn't go back? Do you think it has changed?
That's a great question.
One is an evidence-based, you were there and you know, and the other one you have to guess. But
Right. So there are so many instances that I see of friends and neighbors who tell me how their young kid in college got a Percocet for a sore throat because he said it was still hurting through the Motrin. So, as a mother and a kid in college and a daughter at home, these things haven't changed very much. It's still, when somebody says, it still hurts even though I took Motrin, everybody's knee-jerk reaction in the emergency department or in anyone's practice is, well, then I have to step it up. And these are not chronic pain. These are, this is a sore throat. I mean, we've all had sore throats. They can be very uncomfortable. But this is the threshold that we have changed in the past, so that just because I said the pain was bad, I mean, if I told you it was abdominal pain, it'd be too abstract for you to say, I haven't had that, there's a gradation. But we've all had that bad sore throat, and we all know that we don't want our young adults on these medicines, even if only for a couple of days. It's that whole culture that has to change. So I did not go back to the summer camp this summer for various reasons, but I continue to hear stories like that of examples of just frank, inappropriate prescribing. Even 1 or 2 times is too much for that kind of thing.
everybody, I mean, a lot of you were talking about the obstacles when there is a patient who needs this aggressive treatment, and it is the right thing to do. You're all talking about it's harder to do that. You're talking about being stigmatized. How about and none of you are primary care physicians treating all those sore throats and broken ankles in the non-emergent section, so you're not the ones making this decision. So what kind of progress are we making when the doctor picks up, I guess nowadays it's e-prescribing in some states for controlled substances, in some it still has to be on paper. Thinking about that first prescription, because some of your patients, you do wish they never got that first prescription, and some you say, my job is to help them manage it, and yes, they need these drugs. Is that initial, are people, you're one step removed from it as the specialist, but do you think this discussion of the past year is making the pressures to use the PDMPs, the incentives to speak of the guidelines, are we at the point where the primary care community physician is stopping and thinking, or are they giving an opioid for a sore throat? Are you seeing, from your referral patterns from your colleagues, what are you seeing?
We're actually seeing a lot of change in behavior, good and bad. In some respects, primary care doctors, don't have the time to deal with pain medications anymore, nor do they want to take the risk of prescribing pain medications. And so pain physicians kind of become their automatic go-to. And in some respects, that's good and bad, because there are some patients where I say, well, they need minimum pain medications, and I hate for healthcare dollars to be spent on specialists when it can be mostly kind of cared for by primary care doctors. It's a mixed bag of, still there's that stigmatism of anybody on pain medications can abuse it, and it's a terrible thing, and those patients being sent towards, pain specialists like myself. But I think overall, these guidelines have had a tremendous positive effect, just from how pain, doctors, myself, and primary care doctors are much more careful about who we should start on opioids and who we shouldn't, and should be escalated to, someone like a pain physician. And even for us, before we, provide pain medications that are stronger, we want to make sure that there is adequate pathology. We'll get imaging studies and things like that.
And what are you hearing or seeing?
Can I just interrupt something? I'm sorry. Twitter is going nuts because Britt hasn't talked in approximately 11 minutes on this panel. Can somebody ask a chronic pain patient a question?
We will do that. She's here for a reason. We'll get to her.
You've been talking to everybody else, though.
She's she's indicated when she's wanted to speak, she catches my eye, and she's
But I
spoken.
will say, though, that I do feel like, once again, I'm sitting here and the discussion about the chronic pain crisis is happening around me again when I'm right here, and it could be happening with me, and we could be having a very real discussion here.
And that's being echoed on social media right now.
So to that point, and thank you for bringing it up, I think one of the things that we're calling for is to have greater interaction and integration of the patients in this voice. And so what we've done here at Stanford and what other centers are doing are patient family advisory committees, where we bring the patient's voice into how to prioritize, how to make decisions. And so thank you for bringing that up. With regard to the question that you posed, I think, first of all, a tremendous amount of compassion for the primary care docs, who, as we all know, just have a few minutes to spend with the patient. They are inadequately informed about pain. The average physician gets, I think, 7 hours in medical school about pain management. The average vet gets 40 hours. It's great if you're treating a dog, not so great if you're treating your grandmother. With regard to, is it dropping off? I think that the data supports that it actually is. If you look just back a couple of years ago, what you saw was the #1 prescribed medication in this country was Vicodin, the hydrocodone acetaminophen combination, at 131 million prescriptions. Just released this year, it's dropped to #3 for the first time in a long time, down to 97 million, behind Lipitor and I believe it's Synthroid. And so we are seeing a drop-off. Is it because of the guidelines? I don't know. I think there's also a lot of fear-mongering out there, and the docs are just running scared.
The question I was just about to ask you, you talked about needing them to control your pain and also really hating them, right? They tie your guts up. They're not fun to take. I was going to ask, what would you like? What would you like the system to get you that you can't get now? One of them is some of it hasn't been invented yet. Here's a researcher looking at. I mean, hopefully we'll have drugs that aren't dangerous, and that we'll have a next generation that. But that's not tomorrow. I mean, everybody would love it if you had a really strong, powerful pain killer with no side effects. We're not there yet. Maybe you've got one in your lab that we'll learn about soon, but probably not immediate. What would make it easier for you? There's competing needs, right? You need to be treated. You need to have your pain taken care of. And we also need to have Jean Marie not have dead 20-year-olds every day. So what are you hearing, and what do you need, or what do you want to hear?
Well, I'll go back to what I said at the very end of my talk was, making assumptions about being able to do it better than me. I had heard mentioned in your talk that you would never take an opiate and you would never allow your daughter to take one. But I'm curious, did you use an epidural during birth? And I think it's really easy to assume that you wouldn't if you haven't experienced some of these things, especially like CRPS, which is ranked above childbirth. When I experienced that pain, it instantly brought me to a level of, you understand suicide. You start to understand suicide when your pain is not treated. And what I say as far as to what I want and why I don't like taking them, it's not even necessarily at this point that they make me feel that different on a day-to-day basis. I don't have any sort of feeling when I take them except that I'm just able to function. They do nothing to my head and my ability to work. Actually, my ability to work is much more improved. What I want at this point is for the stigma to be reduced around me, because I have such self-stigma on myself that has been kind of placed on me by media, a lot of those headlines that I've seen. And the problem is that the guilt and anxiety that I have around the openness of taking an opiate, of having that discussion with my doctor, of being in this room and saying this to all these people is really difficult. And what I want is for us to actually look at the base problems in this country, not looking at overdose and constantly talking about overdose, but going back to what are really the problems that led us here. How do we get back to research that actually gets us back to dealing with the pain in the first place? And just this last July, the president signed into effect the Comprehensive Addiction and Recovery Act. If you look at that, that's $181 million annually that have been allotted. Only $25 million of that annually is being placed towards preventative care. The rest of it is towards law enforcement, education, awareness, these things. That doesn't mean anything to me when you're actually living with chronic pain. That needs to be placed on actually looking at the real problem. And the problem is we're talking about a lot of bureaucracy here. And the more we focus on bureaucracy and actually don't listen to the patients that are really dealing with these things, we're not going to come to the solution. We're talking around a problem that's over here, and the real problem started way over here. And we're talking about addiction, misuse, chronic pain, all in the same context, all on the same stage, and really they have no place. We need to be segmenting these conversations separately and having them very separately from one another to be able to accurately deal with the problem. So that's what I want, is to really step back and look at the real problem.
What's in the pipeline as a researcher? What are you hopeful about? Because you wear two hats. You're a researcher and you're a clinician. So
Yeah, I think we don't have anything in the pipeline that is going to immediately be a non-addictive agent that's going to be as effective as an opioid. There are a number of substances out there that pharmaceutical companies are working on. I think what I'm most optimistic about is figuring out what works for whom and why. Why is Britt able to take her doses of opioids, remain highly functional, not run into problems? We need to be able to leave Britt alone.
Or learn from me.
And obviously, as I talked about it earlier, learn from you, but also identify those people who are vulnerable and who will run into a problem if they are exposed to an opioid, and then find other solutions for them. It is a matter of that preventative aspect. We need to treat these as public health issues. And I think we're starting to raise awareness that if we can identify those people who are vulnerable to either chronic pain, vulnerable to misuse of opioids after exposure, we'll find other solutions. And I think we're going to be closer to getting there than, quite frankly, having the Harry Potter magic wand that's going to wipe away all the pain anytime soon.
Right. What about, you were talking about my understanding was that study was an acute episode in an emergency room. You weren't saying there was no place for opioids ever, right? You were the broken ankle or the patient you don't know.
Yeah, I don't think
Wanna
anyone
elaborate?
sees as much pain as I do. I see trauma, I see acute, huge bone fractures, car crashes, people with terrible cancer pain, people with various chronic pains. We use a lot of opioids in the emergency department, and I'm the first person to say, give more, this person's still uncomfortable. There is no world without good pain management where I need to work. But that has spread into a different kind of prescribing in the healthcare systems over the past 15 years. It is scaling back a little bit, I would agree, but we need these drugs. We just need to be conscientious about it.
Cindy, how much overprescribing is there still in the dental world?
I think there's
There was a time when you went to the dentist for particular things like wisdom teeth, right? And a lot of it is teenagers, and you'd go out with 30 days worth of, assuming somebody was going to be in pain, that they would need 30 days worth, right? We're not hearing a lot about that, but
there's been some efforts in this space, but there's probably still more work to be done. And I think one of the things that's important when we talk about pain is recognizing that there are different types of pain. So in general, for a dental procedure, Motrin is actually going to be more effective with you because the procedure is causing a lot of swelling and the drug works that way. So I think among all professionals, there's a need to have a better understanding of the physiology of pain and what works for given patients. And one of the things, I think this is such an important discussion, and to hear Britt's perspective on this, because when I started my career, when I used to practice, we were in a point of time where we talked about pain as the fifth vital sign, and we weren't treating it enough. And then the pendulum swung the other way, and we started treating it too much or with the wrong therapies and in the wrong ways. And we are at a critical point where if we don't address this appropriately, we could potentially swing back to the point where we started 20 years ago. And that's not helpful either. So I think conversations like this, where we're bringing together everyone with these different perspectives, I've learned so much just from my co-presenters today. And it's important to keep having that open dialogue as we look for the science to help us along the way.
And my fear is the pendulum is swinging so far in the other direction that I hear every day from patients that are being cut off from their medications, sent directly into withdrawal, which is not safe physically. emotionally. And the problem is many people are getting cut off to the point where now they are considering suicide. Now they are considering heroin. Now they are considering alcoholism. And it's because we're swinging so far with the pendulum that we are hurting a lot of people that are just innocent bystanders in what we are calling the opioid crisis, when really what we have is a chronic pain crisis that we're not addressing in this country.
And we're not paying for the alternatives that would alleviate, or you might need it in conjunction with a medication, but the other things that work, for some, again, different people will respond differently, but things like acupuncture, making physical therapy, insurance companies don't make it easy. They make it cheaper to get the drugs than they get, cheaper and easier than the PT. Acupuncture, mindfulness, cognitive therapy works for a lot of people in conjunction with other things. So we need a self-correcting pendulum, right, that will somehow either let us avoid the dangerous, protect the people who need it, and we need a medical system that understands, and doctors who have time to explain to patients that these other things work, should be valued and given that option to patients to figure out what they need. And different patients will make different choices. I mean, I would make really different choices than my husband, I'll always go for the ice pack, he'll want the pill. Okay, I think that we're pretty much out of time. The clock is going in the other direction. So thank you. I hope you do feel listened to, because it was my intention. And this is a conversation that we could have again next year. Thanks.